Hello, everyone. Thank you for joining us tonight. My name is Sandy Youssef, and I'm the Manager of Professional Education here at Ethicon. Tonight is the first of our sessions of the Clinical Skill Advancements and Case Reviews for PAs and NPs in Spine and Joint Reconstructive Surgery Learning Series. Tonight we will focus on adding value as a PA or NP. As I mentioned, this is the first of a 12-month learning series that will be executed throughout 2021. We enjoy you guys joining us tonight, and we hope you enjoy the webinar. Please remember to submit your questions. You can do so by utilizing the Q&A tab at the bottom of your screen. Thanks for joining us, and I'll hand it over to our moderator, Josh Beardsley.
Great, thanks Sandy, I appreciate it, and thanks everyone for joining us. We are very excited about kicking off this new series. You know, you've got a great faculty here, and they're going to introduce themselves here in just a minute, but just want to take a moment to thank Sandy and her team and Johnson & Johnson for continuing to support the PA profession, the NP profession, and for really investing in the education of the career of the professionals represented here. This is the first of the series we'll be doing this monthly, and we're excited about this topic, which is adding value as a PA or NP and how you can do that. We've got great experience here. So a little bit about me. My name is Josh Beardsley. I'm currently the Vice President of Clinical Service Lines for the Florida Gulf Coast region. I'm in Pensacola, Florida, but most recently was in Southern Arizona for the past several years. So I want to go ahead and turn it over to the other faculty to just give a brief introduction so you know who's here, and then we'll kick things off with a poll. So Jerry, maybe introduce yourself.
Thank you, Josh. My name's Jerry Bookert. I'm a PA in Houston, Texas at Houston Methodist Hospital. I work in orthopedic oncology and spine surgery. I'm looking forward to kind of having this information exchange and interacting with everybody in the coming months.
Great, thanks. And actually, Sarah, before I turn it over to you, if all of you who are on board listening, if you'll just send a quick message in the chat box, just let us know where you're from, maybe what state or region of the country you're in, so we kind of get a feel for where you are. And while we're doing introductions, we can kind of take a look at that. That'd be great. Thanks, Sarah. If you don't mind introducing yourself.
Yeah, my name is Sarah Holland. I am an orthopedic surgery PA at the University of Wisconsin in Madison, Wisconsin.
Janine?
Hi, I'm Janine Gargiulo. I am a PA, and I'm based in Alexandria, Virginia, which is just outside of DC, and I do orthopedics, specifically total joint replacement. And I'm looking through some of the attendees, and I'm very pleased to see some of my coworkers are here, although they're not in joints, but see some of my my very fun coworkers here still socializing in ortho. So I'm happy to have everyone. Looking forward to the web series that we have planned for the year.
Fantastic. Again, thanks so much. And we have been privileged to work together as faculty for a number of years now. And Sandy always jokes around about how much experience we have. She says we have over a century of experience. I don't know whether that's a compliment or not, but when you combine it, but it's a privilege to work with Jerry and Sarah and Janine. And again, we thank you for joining us. I did not mention, but most of my clinical career, actually all my clinical career was spent in neurosurgery. So really happy to share any experiences we have with you. Before we get started, we have a poll that we want to put up. And this is just a very basic question. Before we talk about adding value as a PA, or NP, we want to know, generally speaking, do you currently feel that you're adding a significant value in your job? This is a general topic, and then we'll get more specific as we move on. But go ahead and answer this poll. Again, do you feel that you are currently adding value in your role as a PA or NP in your current job? And obviously, these are anonymous, so nobody's going to know your answer. So be totally honest, and that'll help us know a little bit more about which way to take some of these conversations. So let's see. Okay, so I don't know if you guys can see the results, but it says, so we have 85% of respondents said yes, and 15% said no. So we're just at just under 30 respondents. So that's perfect. And I think that, one thing that I think is interesting and we should point out is that our current environment right now, it really is difficult to determine the value that we add, because we're all doing things that, most likely all of us are doing things now that we weren't originally, didn't originally sign up for. COVID has really disrupted our industry in a big way. And so I think one of the things that you'll hear from your faculty is how their experiences have been through this transition, and then how they've found ways to add value or add additional value, even in the face of having to, to change our, basically what your job was or what you were expecting to do when you took that position. I think most of you may recently know we're one of the top professions, and it's a privilege to do that. I think the most recent poll showed that PA was the #1 job in the country right now, and I think that just goes to show, because of the versatility of PAs and NPs, we have the ability to add significant value in a lot of different ways. So kind of jumping right into it, the first thing we want to talk about is specifically in the OR. How do you feel that you're adding value in the OR? So before we turn that over, Jerry's going to give us a little bit of perspective there. But as we do that, there's another poll that's going to pop up, and would like you to kind of take a look at these answers. It says, how do you add the most value in their OR? You specifically or individually, and it says select your top 3. So let's see, go ahead and pick where you think you're adding the most value in the OR, whether it's with your surgical skills, prepping and positioning the patients, reviewing x-rays, coaching the scrub techs and the support staff, residents, fellows, anticipating the surgeon's next steps, and or creating efficiencies and reducing OR times. So let us know the top 3, and then I will give you the results there. And Jerry, while we're waiting for that, maybe you want to kind of waiting for the results there, if you want to jump in a little bit and talk about what you're doing in the OR now, and then I'll give you the results as they pop in.
Yeah, no problem. So so right now we just got shut down again with elective cases in Houston, which we're hoping to end here in the next 10 days or so again. Fortunately, or in some ways it's fortunate, but I do orthopedic oncology, and those cases, they're urgent or emergent generally. So we do add those on a fair amount without any limitations. From the spine side, unless there's acute motor loss or a spine tumor or something like that, we've been pretty aware of a T2 to pelvis taking an ICU space may be problematic. So we've been trying to minimize those kind of cases and doing stuff that's truly urgent. We were open for about 5 months, but then kind of got shut down in early January again. But again, we're hoping to reopen in February.
Great, here we go. The poll results just came up, Jerry. So I'm gonna jump in here real quick before you keep going. So 40% said. So let's see. The top 3 would be anticipating the surgeon's next step is #1 at 77%. #2 would be prepping and positioning the patient at 63%, and then it looks like #3 would be creating efficiencies and reducing OR times at 57%. The lowest of the 3 of the answers at 13% was coaching the scrub techs and the first assistant surgical residents and fellows. So I think that's an area that we can talk a little bit about, because that is an area where we can truly add significant value. The other thing I did want to mention before we get into this, if you have any questions, if any of you have any specific questions that you'd like for us to answer, go ahead and type them in the question and answer box. You won't see the questions; those are going to come to us, but we will answer those questions for you. So if you don't see it, pop up in your box, it doesn't mean that we're not seeing it. So please feel free to jot any questions down, and we will tackle them as we go. So Jerry, again, if you want to just kind of elaborate a little bit more on, specifically in the OR setting, what kind of value you're bringing.
For sure, and I think it's interesting looking at that poll, because I think as you go further along in your career, those numbers may evolve over time. And I probably would talk about resident and fellow coordination more than anything as something that I do currently. And, it certainly varies in the type of environment you're in, whether you're private practice and paired with an individual surgeon, or whether you're in a residency or fellowship type program where you might be kind of bridging that gap or taking the lead a little bit from them and showing them kind of the ropes. So I'll kind of talk through a few different concepts here. the first thing I'm going to talk about is before you even get to the operating room, and it relates to the people that invited you here to an extent, and that's communicating with the surgical team that's not necessarily from the hospital side, but the reps. I know from the spine world, when we're doing all these spine cases, communicating with our reps and making sure we have the right hardware there in the operating room, whether that's through the operative reports or reviewing films with them. Early on, you're kind of novice to the different types of instrumentation, whether it's in a hip or a knee or the spine, but having that dialogue and making sure before you walk in the door, there's not going to be a big surprise, and making sure they have what they need. And if there's a junior rep, really communicating with them and kind of making sure they have everything teed up. The circulators and the scrub, they may be a little bit helpful in that as well. I noticed on there people, that was also on the list, something that people didn't do as much. And I think that early on, I listened to our scrub a lot. And at this point, it's a little bit different interaction with how we do that. And I help guide them, especially the newer grads as they progress along. After that part of it, as you walk into the OR, coordinating with nursing and anesthesia, there's some value to some things that occur that you may feel is the physician side, or I never really, one of our sayings, and Josh has heard me say this 1,000 times, is you're never just a PA or just a nurse practitioner. You're part of the surgical team, you're part of the team, and you're making decisions and helping kind of coordinate everything. And as you get more comfortable with things, your voice is a little bit more valuable there in the operating room. And things in the spine world, we talk about stuff like tranexamic acid and having blood in the room on a big case, things that you can ask about with anesthesia, what kind of lines you may need, and coordinating those conversations. And similarly, orthopedic oncology with some of our big, massive joint resections and such, similar dialogue. Do we have blood? What's the starting hemoglobin? And then in some of the joints, I know ideally we're trying to do everything as an outpatient and pretty quick, but if some of the mega prostheses, do you need a Foley, and having those conversations and not having it be something where they need to go find the surgeon or you're not really sure, and kind of educating people there. And also pre-surgery, looking at the suture choices, do you have everything set up for the case, and have that stuff open and ready so you're not scrambling at the end of a 2 or 3 or 5 hour case, depending what you're doing, and trying to find something to close that should have already been there. A lot of people answered that positioning is an important step for them. And certainly I encourage people as much as possible to own that portion of the operating room. In the spine realm, we do some pretty fun procedures pre-positioning at times, putting on a Mayfield or Gardner-Wells tongs or a halo, and having all those pieces and learning those techniques. Certainly your first day in the operating room, you're not doing that stuff, but pretty quickly you can get up to speed with that. And then you start training the residents and fellows how to do things appropriately. And I think there's a lot of value to that. Clearing your for imaging, clearing for the C-arm, whether it's a Foley or the neuromonitoring from underneath the bed, all those questions that everybody kind of asks, or that during the case become a holdup because you haven't really prepped things on the front side. There's so many steps along the way. One of the acronyms that we use in our operating room is called ABLE2. So did they get antibiotics? Is the back table ready? Meaning, does the rep have what they need? Do we have suture, all those things? Do we have the lights on the wound? Do we have, is the patient evacuated? Meaning, is there a Foley? And if there is, do we have that up and out of the way? And then 2 is timeout. So just kind of those 5 steps. And we just talk about it on everything. So you should never be scrubbing in and the lights be on the wall and you haven't put them over the wound. Those are all just little steps to just expedite things. Then during the case, I'm maintaining kind of the lights over the incision and just staying a step ahead of the surgeon as far as you're seeing what they're looking at and you're staying with them along the way. Certainly from a surgical technique perspective, whether it's hemostasis or techniques that are needed during the procedure, retracting or using a burr or different things, and we'll talk about that a little bit in our one-on-one sessions if you have those opportunities to talk. But you want to certainly develop skills that allow you and the surgeon to mirror one another whenever you can, so that you can push those cases along. And I think that's the big stuff from my perspective. I know from a suture perspective in the spine realm, I'll communicate on that. Just we talk a lot about different choices we make in relation to wounds. We've talked a lot about some of the Ethicon products, Stratafix specifically, that we've used in the big spine cases to take down some of our closures from having 6 to 8 packs of Vicryl pop-offs to just using a running symmetric stratafix to try to close the fascial layers and taking down our surgical times on like a PD scoli case or something like that. Sometimes up to 30 to 45 minutes, depending on the size of the patient. I'm in Texas, so sometimes we have a few extra layers. And you want to just really try to own that part of the procedure from the spine side. As soon as we put the rods in, typically my surgeon would step out of the room and we would take care of everything from there. And certainly as time goes on, hopefully all of you are able to kind of find that role. And I know, Janine, you wanted to kind of talk a little bit about the joint side of things.
Yeah, and it pretty much emulates what you were saying. I think it really comes down to like a team mentality in the OR. As far as what you were saying, we have a fellowship program of 4 guys a year doing a joint fellowship. And so, it's, from the bottom up, kind of when I was the new person 12 years ago, really learning from everybody in the room as far as experienced CRNAs, and my scrub tech and my nurse really took me under their wing and said, like everybody, I think that was the #1 answer, learning the steps. Here's the steps behind what we do, and here's why. And so that's who I really learned from, and we would practice as we ran 2 rooms and getting really our flow and our efficiency down. So kind of using the team mentality. And now I've kind of climbed the ladder, if you will, where I'm someone who's teaching the fellows at this point. So that's really something as far as, pre-op, what we can do with a lot of the prep work, as you've said, with either templating or communicating with reps. Everyone pulls in as part of the team to give the patient the best outcome. And, I think there's another part of kind of that trust factor, really, where now everybody on the team really has to have a good level of trust with each other. And that goes into what you were just saying with owning wound closure. That's really kind of my home run in the OR. I think that's the biggest place that I add value, is that I do that rather independently. And that's where I'm independently making all of these decisions. So, while I'm a good asset in the OR, pre-op, setting up, positioning, and all of those things, even particularly in joints, which I would like to say is important, but I realize here sometimes spine wins. And Josh is laughing as I say that, but what we do is important, but really, once the implants are in, that's where I really start to own what we're doing. And so that's where some of the suture choices really come in. And, I'm trusted to even do some homework or say, hey, there's something new I want to try, or hey, I've done some research, or hey, I've talked to some reps about things. And that's where specifically, I turn to my sutures of choice, and we've actually transitioned over the past couple of years. The one that I use specifically, I think, for my own efficiency as far as OR time, which is good for us in the hospital. And later, I know we'll talk about adding value to the patient. I think this could even fit in that section, but is using some of my Stratafix symmetric is, good for the capsule. But my favorite one is a monocryl Stratafix. And we don't have to get into the really nitty gritty, and we'll have an opportunity, if you don't know anything about what I'm talking about, we can deep dive into this separate. Sandy's got an option for that, but it's essentially a monocryl, and instead of having to tie knots and do all of that, it's got a loop on the end. So you start your suture and the needle goes through the loop and it's done, and you run it down and back. It's very efficient. It's kind of an antimicrobial coated suture, and I think there's a lot of benefit both for the patient and providing, again, value in the OR. So basically the wound closure as a whole is where I start to own my value the most. And like we said, I do contribute to every one of those options, I believe, but it's taken me 12 years to really feel like my own skills and, feeling an important part of case prep and all of that has really come along in the wound closure. But that's, my biggest piece, I'd say, at this point.
I think that's great. And I think that you bring up a lot of good points. I think the other thing to keep in mind as well for the team here, whether you've got 1 month of experience or whether you've got, 10, 20 or 30 years of experience, one other area that you can add significant value, and I would say critical value in the OR, is being a safety net for, the patient, the surgeon, whatever you want to talk about. I mean, one of the best things you can do, even as as simple as making sure you're counting the levels on the x-ray. Make sure you're double checking, that you're at particularly for spine. And I'm not gonna, I spent, again, my career was in neurosurgery and spine, but I know Sarah and Janine can speak a little bit more to the ortho side of things, but spine is definitely one area where you have to speak up. If you're not at the right level, or you don't think your surgeon's at the right level, take the opportunity. You're never too. There's no more value you can add than making sure you don't do a wrong level or wrong side surgery. So even things like that add significant value. The more efficient you get in the OR, and this is again throwing on the administrator side, hat is, I think the previous data was around, I think it was $98 an hour or something to that, or a minute, something to that extent, is how much it costs to run the OR with a patient in there. When you factor all the costs in, $98 a minute. So if you can become efficient in, Janine, like you were saying, in wound closure, and you can shave 5 or 10 minutes off of a wound closure, that's a significant value add just from the perspective of cost savings, to the patient, to the facility, not to mention the efficiencies that you're creating for your surgeon. So just a couple things to keep in mind, but I think those are all really great perspectives. The other thing so just to kind of give you guys a preview, the other topics we're going to hit are value in the clinic, value to your surgeon, and then we're going to wrap up with value to your patient. So as we talk about these topics, think about how they each apply to each other, because we're not talking about these in silos, right? They all add value and overlap in some way. So the closure that you're doing, Janine, certainly it's valuable in the OR, but that really translates into how does that affect the patient when they go home, or the cosmetic effects. So all of these kind of play into each other. And so I would just keep that in mind to those of you who are on with us. Just, how can you apply these to different different areas or different topics? So moving on to the next one, we are going to talk about adding value in the clinic. And so we're going to throw a poll up here for you guys to tackle. And the question is, where do you find you bring the most value in the clinic? That could be seeing global period patients. And for those of you who don't know, global period is the 90 days after surgery, the patients, your post-op visits that you can't bill for. Seeing new patients, seeing second opinions from outside surgeons, seeing second opinions for self-referrals, working up patients for surgery, or maximizing conservative treatment with patients. So again, select your top 3. And while we're tallying those, I'm going to turn it over to Sarah, who's going to give us some perspective. And Sarah, if you can just do a quick little intro, then I'll jump in with the results of the survey, and then I'll turn it back over to you as soon as we get those results.
Absolutely. So when I think of how I add value to the clinic, I think there's kind of 3 areas. One is I can provide continuity of care. I think that the poll really lends itself to that portion. Providing availability, and that comes in a couple of different ways, whether I'm available to patients or whether I'm available to staff. And the other area that I think I add value in is forming relationships. I think all those add value to the clinic, and especially with your clinical staff, which all helps relate to a good patient care outcome. So one thing I like to think of is kind of reversing the question and thinking, if you were to ask my staff, how do I add value to the clinic? What would they say? And they're probably not going to say adding new spots to see global patients or anything like that. But they're going to say, she's always available to answer a question, right? I'm never afraid to ask her a question about a patient. Even if I've never seen the patient, I'm that approachable, available person. And as Josh likes to say, a lot of times you kind of end up translating for your surgeon as well, whether that's to your patient or whether that's to the staff. And if you think about it, you're almost that first line for any questions your staff might have.
I'll jump in with the results here real quick. That maybe will help. You can add some color based on the results of the surveys. It says number 1 with 73% is seeing new patients. Number 2 with 70% is seeing global period patients. And then number 3 at 61% would be maximizing conservative treatment with the patients. And then the lowest actually is at 6% is seeing second opinions from self-referrals. So actually, Sarah, you're probably going to talk about this, but would you comment on the value of seeing global patients? Because a lot of people would say, well, that doesn't really add value because we're not getting paid for it because, you know, we're just seeing patients that we can't get paid for. But I know that you and I have talked about this before. So the real value is not necessarily the number of dollars that you're bringing in, but there's other factors. Would you mind speaking to that when you as well?
Right. And that's kind of the hard part with measuring the success of our job and the success of our role is there is a lot of intangible things that we provide to the clinic, to our patients, and to our surgeons. So if we are seeing those global patients, you know, it may not be as easy to trace our billable hours, right? We may not be bringing in as much income, but we're freeing up our surgeon. We're adding a lot of value to the surgeon so that they can become more efficient. You know, kind of adding more flexibility so that they can see maybe the more complicated patients or themselves being more productive. So that is a spot where we add a lot of value, but it's all part of that kind of continuity of care where most of us are seeing our new patients and we are walking them through that conservative treatment time. We're the one providing injections. Again, kind of teeing them up for surgery, making that visit when they find out, when we decide that it's appropriate for them to meet with the surgeon, kind of teeing them up so that the surgeon can be as efficient as possible. And that's really a lovely thing that we have as a PA or NP is being able to see the patient through the journey. We're able to establish a lot of trust with them because we have seen them on multiple occasions. And then if we're lucky enough, even being a part of their surgery. And that's also a nice thing to be, you know, kind of that relaxing, kind of familiar face that a patient might see during the time of surgery. And then after surgery, again, seeing them in that global period, walking them through everything that was done through surgery and kind of wrapping up their care. So that is, I am seeing most of my post-operative patients. I am seeing most of my preoperative H&P patients. But that's kind of just, you know, that one form of it, right? So I am available for my patients. But on the other side, I also see patients for my ortho urgent care. So I always have spots open in my clinic schedule for those last minute add-ons, just to kind of fast track any traumatic injuries. And that way that allows the patient to have more flexibility when it comes to scheduling appointments. And for the same part, kind of frees your surgeon up too, so they're not seeing these kind of, you know, knee pain for one day type of patients. And, you know, you can look at this as kind of burdensome if you choose to look at it in that light. And certainly if I see a chief complaint of, you know, a 78-year-old female who fell and can't walk but doesn't want to go to the ER, you do kind of have that sense of futility because what can I do in the office if this patient has a hip fracture kind of thing? But there are a lot of sports medicine and kind of non-operative issues that can come into your clinic that just make you a well-rounded orthopedic PA or spine PA, kind of knowing how to treat all of those non-operative problems that can come up that even, you know, in your post-operative period, you see a total knee patient who, as you have your hand on the door, says, do you have any recommendations for plantar fasciitis? You know, that's helpful because without hesitation, you can give them a treatment plan. And that's because you've gained that knowledge from experience from being available to see the patients that need to be seen in the clinic. You know, aside from that, I think the other important thing we can do is establish good relationships. And we are kind of the middleman between maybe our clinical and support staff and our surgeon and the patient and our surgeon. We're that middleman. So establishing that kind of reputation for dependability, you know, establishing confidence with your decision making because you are an extension of your surgeon, I think can be really valuable in the clinic as well.
You know, Sarah, you talked about this a little bit, but I think one other component that's worth mentioning when you talk about being available for your support staff or for your patients in the clinic, this can't be overstated. I think how many times have we, you know, gotten calls from, you know, the nurse or the nursing assistant or the office, you know, the administrator who said, you know, so-and-so called, they're complaining of redness around their incision or they're complaining of, you know, increased pain. So I sent them to the ER. And that, you know, is often 9 times out of 10, that's the wrong thing to do because these patients don't need to be in the ER. But your ability to be available to handle these calls and triage, like you said, you can see them you can see it as a burden. But the reality is if you can just say, hey, look, talk to me about that patient, because guess what? The ER is going to call you anyways, right? And then you're going to have to go to the ER to see those patients. So maybe, you know, is that something that you have found that you've been able to curtail? Is the number of times your staff just sends the patients to the ER when they don't necessarily need it?
Absolutely. That, you know, it's almost an unwritten rule that our staff never tells our patient to go to the ER unless we tell them they need to go to the ER. And if I think about the indications where I'm telling someone to go to the ER, it's almost never an orthopedic issue, right? It's either I'm concerned of a PE or something like that, something kind of beyond my orthopedic knowledge base. But you're right, if there is any concern with the postoperative course, I want to see them with my own eyes. And I want to be, you know, that yes man, where if my clinic staff comes to me with a patient, yes, I will see them. I don't want to say no, and they end up in the ER with a wrong kind of course of treatment.
Yeah. Janine, anything else? I know that that's one of the favorite parts of your day is the clinic and the relationships you have with those patients. Anything else that you would want to add as far as value add to the clinic?
I mean, I think you've pretty much said it. I see over 1,000 global patients a year, and it's pretty much for this reason. I mean, just today, I was able to avoid sending what would be a mundane cellulitis to the ER from a therapist who was nervous, but knowing the patient, knowing his predisposition to some of this because we've done a previous joint, you know, just having a normal conversation, not letting the patient get too worked up, especially in the COVID era. You know, we're able to easily take care of it just from some conversation. But, you know, the other thing I like being able to do is, I think it was on here, maximizing conservative care with patients. So seeing them as a new patient, and that was high on the list of voting. Maximize all conservative care. That's where you build the relationship and the rapport with patients, you know, because they say, sometimes joking around, like, well, you know, I don't really like doctors. I'm like, well, I'm not one. So that's the good news. You know, there's nothing to be scared of here. And going from there, you really get to know your patient and have an honest conversation. And then I kind of like tee them up for surgery, you know, if you will. So they just see the surgeon, you know, in our office, it's once they get to meet the surgeon truly in the office before surgery, but I can let them pick a surgical date and really go through the true risks and benefits and how it all works instead of them feeling rushed and overwhelmed. It's like a white coat syndrome almost with meeting a surgeon. So I kind of tee people up for surgery as well, as far as adding value to the clinic. And that I know that transitions adding value to the surgeon in a way. Like you said, a lot of these blend together. But as well as the global patients, you know, I do a decent amount of second opinions as well. But seeing the new patients, the conservative care, teeing them up, you know, just kind of the availability factor, definitely.
So as we transition to the next topic, which is adding value to the surgeon, if we could go, there's a poll question we'd like to go ahead and throw up there, which is, let's see, it should be coming up here in a second. How are you most valuable to the surgeon? So this one, I think there's only select one, but how do you feel you're most valuable to the surgeon, whether improving their overall quality of life, improving time management, office relationships, billable time, increasing reliability, or improving organizational and practice efficiencies? So as we answer those questions, Jerry, I'm going to go ahead and turn it back over to you to tackle this topic, and then we'll give some additional feedback as we go.
Yeah, for sure. I want to comment real quick on the improving quality of life, just as kind of a starting point. I mean, I think all of us, we have our career and we take it very seriously. We want to perform at a high level. And with everything that we're talking about, it all comes back to having a quality of life, whether it's satisfaction at work or getting done efficiently so we can be at home. So I think a lot of the things we talk about are related to that, not just for our surgeon, but for ourselves as well. And when you have that good relationship with your surgeon and your practice where you're able to navigate through issues that come up, it allows you to sort of both yourself have a better quality of life, but also your surgeon. And in regards to the bundled care, I'll just kind of mention that. I know you were going to say that, Josh. There was a question related to, has bundled care affected you going back to the operating room? You know, I think in the end, we have to make decisions related to what is going to be appropriate for the patient in that moment. And while some of us are old enough to remember when it wasn't a bundled code, you know, we just did what was right in that moment, but you were able to bill for it in the past, and in the modern day, that's changed significantly. So, I think for me, I'm more focused on just whatever is the best outcome for the patient, which I know is a really generic thing to say, but I mean, sincerely, that's really the only way I try to think about it. I try to ignore the fact that I'm not going to get paid for extra effort potentially, and be as preventative as I can in that situation. So related to, or go ahead, Josh, you want to go through the poll real quick?
Yeah, let me jump on this real quick before you start. So the number one topic was at 31% was improving organizational and practice efficiencies, followed by, excuse me, improving time management at 25%, and then increasing billable time at 7%. Looks like the lowest percentage was increasing reliability, followed by improving office relationships. So so I think that's a pretty good cross section of answers, but yeah, definitely by far it was improving organizational practice efficiencies.
Yeah, and that's kind of my perspective on this as well. As far as the practice goes, in the operating room, we're able to help progress, and Janine talked about this, progressing from room to room, especially when you have multiple rooms, and being efficient in steps along the way, which helps both your surgeon and, again, everybody involved in those cases for the day. But there's a lot of parts that don't really count towards anything, like rounding on the floor before cases and handling things on that side. And I think so often people try to just round whenever they get a chance, and I really try to encourage people, when you have the opportunity to pre-round before you get into the operating room, there's not nursing on the floor or therapist trying to figure out what's the next step, where are we going. And then if you want to do a speed rounds later with your surgeon, that saves them a little bit of energy on the backside, because you've already changed the dressing, you've already answered a lot of the questions, you've written the prescriptions, and you're ready to progress the patient out of the hospital. In relation to reliability, just want to comment on that. I know it wasn't one of our most popular answers, which is fair. There's some questions on there, certainly related to risk factors and ways that we can potentially help optimize the patient going into the operating room if we are making a surgical decision. And I think as nurse practitioners and PAs, we are probably a little bit more in tune with that reality. And certainly there's tons of data to say that that helps affect outcomes on the backside, whether it's looking at a patient that has diabetes. And when you check out to your surgeon, and you've gone in and kind of done a physical exam and a history, having a concise communication that communicates those points very quickly, as well as the fact that their medial joint line is severely degenerative, or that they have a grade 2 spondy with severe stenosis, or whatever the thing is that you're communicating, but include those other risk factors, because that does help affect reliability and outcome. And Dean, in relation to your question, hopefully the more we're doing stuff like that, we're minimizing those situations where we're going back in the global period and doing a washout because a patient with an A1C of 11 was taken back for an elective procedure without getting kind of teed up on the front side. So that's one of the things I just really wanted to kind of touch on there.
I think there's another question that I wanted to jump on. So how long do you feel it took for you to gain your bearings in the ortho or spine, so you felt that you were adding value rather than taking time to be trained? I think that's a great question. I think that you have to change your way of thinking to away from taking time to be trained to giving time to be trained, because I mean, I will say I spent, in neurosurgery anyways, I would tell people when I was hiring them, you're not going to sleep well, or you're not going to feel comfortable at all for at least a year. And then you're still not going to feel confident in what you're doing, because we really need to be continuing to learn every single moment. I always say one of the most dangerous places we can be as providers, whether it's neurosurgery, spine, ortho, joint, is standing still, right? Is stopping to learn, is stopping learning. And so I would say, don't ever feel like you're taking away time from whether it's your surgeon or your peers to train, because all that time that you're taking is actually time that you are giving of yourself to become a better clinician. And that time is given to your surgeon to make their practice more efficient, to be a better provider or clinician for your patients. So, so change the perspective a little bit, but then also understand that it's not something that you're going to feel comfortable with in a month. If you're just starting in, I mean, it took, Jerry and I, spent a lot, spine, and, it wasn't, I mean, it took time before, we both put in pedicle screws, we open, we close independently, pliff and do all those things that are, but we also have, it depended on your surgeon as well. And we do talk about this a lot in the live courses, is you have to be willing to have a difficult conversation at times with your surgeon and tell your surgeon what it is you want out of your career. And if you can't have that conversation early on, you know, it was very early on in my career when I told my surgeon, this is what I want. I want to be, you know, I don't want to just stand in the OR and hold a sucker. I don't want to just do rounds on the floor or see clinic patients. I want to really be engaged in the OR. I want to know what you know and do what you do. And my willingness to have that conversation with him resulted in his willingness to invest in me and invest. And so by the time that, you know, within, I guess, a year or so, I was doing a lot of the things that I talk about, putting in screws, opening, closing independently. So you got to be willing to have those conversations, put in the work. I think, you know, Jerry, before we jump on to the next topic for Janine, do you have anything that you want to add to that?
No, I just think that just being in conferences and meetings like this, and that's part of what we hope is to create an opportunity for everybody to add depth of their knowledge and kind of gain some experience and exposure. Certainly this topic is more about kind of the behind the scenes stuff, and as we get into some of the next talks, it's going to hopefully escalate people's comfort level with difficult conversations that we deal with on a clinical side. So taking these opportunities, if there's fellowship courses, M&Ms, whatever things you have opportunities to go to, especially early, go to them and try to train like your surgeon trained and gain knowledge so that when you get into the operating room, you're speaking the same language. And I think that really helps kind of connect you to your surgeon even more.
Sarah, did you have something that some perspective there?
I do. You know, I think when we're talking about adding value to the surgeon, you know, it goes beyond adding productivity, which was kind of the #1 answer to the poll, right? Improving organizational and practice efficiencies and kind of focusing on those billable hours, seeing as all those patients. But I think it becomes more evident when we talk about working in the operating room as well. And when you think about it, when someone asks you what a PA or an NP does, you think about how you describe that and think about what aspect of your job gives you the most pride. And I would guess that most individuals who work in OR would say wound closure. Wound closure gives me my greatest source of job satisfaction. That's what I'm most proud of owning. So I would say take advantage of that passion, because mastering your technique and becoming well-versed in wound closure, the different wound closure devices and different techniques is really what's going to help demonstrate your value to your surgeon. So taking part in these webinars, taking advantage of our Ethicon Expert Exchange, where you get a chance to have one-on-one discussions and sessions with Ethicon faculty to go over different wound closure devices, different suture devices, is really a great way to improve your technique and really expand on your knowledge of wound closure, which is very evident to adding value to your surgeon as well.
And I was going to say, you know, when people ask me how long, if I had to put a number, I'd probably say 2 years until I really felt some of that confidence come. And it does depend who's teaching you as well, because they truly have to invest in you to get your investment back into them. But I know at the end, I think we can probably share this. Sandy will help us, but there is a PA page, and that's something that I still at this point show my students and go on to. So that's something to probably take note of. But, you know, at the end of this, we'll show you the PA page, and Ethicon's made something just for us. And I constantly go to that, show students or reference that myself. You know, it's made just for us, and find a good resource or make your own list of good resources, especially as you're learning, where you can constantly go back to something that was invaluable until I really felt, you know, confident, comfortable. But since we're always learning and on this kind of journey, you know, that's valuable.
I think that's a great, and actually I know we're going to talk about or show that resource here in a little bit. I know we have just about 10 minutes left, so I did want to make sure we tackled this last topic about adding value to the patient. So we're going to throw a poll up here real quick, but while we start that, Janine, I know that's something that you're passionate about, is how are we providing services and adding value to the patient? Because at the end of the day, this is what we do. We got into this business to help people and take care of patients. So so if you guys could answer read through the poll here, what do you think brings the most value? I'll let you guys read the answers and just select one, but for the sake of time, I want to go ahead and, Janine, if you could kind of jump into that topic, and then I'll go over the results as soon as they're ready.
Well, I think you kind of hit it. You know, we all got into this at some point, and I know you and I have had this conversation because at some point interviewing for school, we all said, you know, we want to help people, and the patient and value people. So, you know, we add value to the OR and add value to the clinic and add value to the surgeon. And at the end of the day, all of those things really culminate to, you know, we're all together as a team helping the patient. That's the number one, right? So we have to be a great patient advocate. You know, we find our personal connection with them. Like Sarah said, we're the middleman, you know, so we can coordinate care and optimize care, I think is the word we put there. I'm curious to see what the poll results are, but, you know, the personal connection, or we already said we're available. My thing is I love doing patient education and any type of education. So I know one of the, let's see.
Oh, here we go.
Yeah, one of the stories, I'm curious to see where this showed up is, you know, recently I had a patient who came in for surgery and long story short, she ended up in rapid AFib in pre-op, so she had to be canceled. And as she went through her workup, she was going to get back on the schedule, everything got taken care of, and it turned out that I was going to be actually gone. I was having a surgery myself. I was having shoulder surgery, was going to be out for 6 weeks. And she was adamant that she would not be having surgery until I was back and in the OR, which was going to be 3 months for my own recovery until I was back in the OR. And there was no way that she would be having surgery until I was back. And true to form, she has scheduled her surgery for next month and has been waiting until I will be there. So I count that as like her true peace of mind, you know, and being her strong patient advocate, which did not score very high here on the poll, but
Well, you know, it's funny. So the top two, it's actually pretty close. Almost across the board, 31% said personal connection, 31% said your access and availability, and then 24% said the depth of patient education. So, but the lowest percentage was strong patient advocate and true peace of mind. Which is really interesting. I think that's one of the greatest things we can give our patients is to be a strong advocate. And Sarah mentioned this before, but I used to always say my job was to translate for my neurosurgeon. Patients need a reliable or relatable person to talk to, and they're going to tell you things that they aren't going to tell the surgeon because they're oftentimes intimidated by the surgeons for whatever reason. So I think when you talk about being a patient advocate, Janine, I think that's a great privilege of ours to be able to be present in our patients' lives, sometimes at the most difficult times they'll ever experience in their lives.
I think so too. I mean, I probably would have voted the same way, but truly having that connection, you know, people truly trust us. They feel that they can really open up. You know, we're not going to be judgmental in any way. They feel that they can be open and honest, and we are accessible to them too. They really know that we take the time to explain things a couple different ways until we feel that they really get it, whatever we're discussing. And sometimes even in the pre-op planning, you know, like Jerry was hinting at, you know, having a conversation about their risks of surgery. And sometimes it is weight loss and why their BMI matters because their risks are higher, and explaining the reasoning why we make the decisions that we do. Or once we get in there, you know, again, going back to wound closure, that knowing my patient and knowing their history and knowing that pre-op I worked them up completely, you know, I'm going to pick the best wound closure for them. And that gets back, and again, we could do Ethicon expert exchange and hint at that, but talking about, you know, my favorite Stratafix suture, if I don't think that's the perfect thing for them, putting in interrupted nylons or going to a secondary or putting on a prineo or, you know, going to alternate methods of closure, you know, I will optimize and individualize their care. And they know that I truly care for them on an individual basis. And even though we do hundreds and hundreds of joints a year, they're not just coming through a factory. So they have the comfort of knowing we're really good at what we do, but they're still just not a number. They're still a true patient with a true identity. They know that I'm watching over them as an individual person. So
yeah, I think that's exactly right. Optimizing patient care for individual patients is key. I know we are running out of time here, and I hope that you guys all get the sense of how passionate and excited our faculty are about the topics that we get to talk about. We're going to throw up one last poll that just asks you, following this, do you feel like maybe there's areas where you can add more value in your current role? Yes or no? And I think that this is a series that we are very, very excited about. We're going to do this before we turn it over to Sandy. We're going to do this every month for the next for the year. This first topic was really just geared towards having a general conversation about lots of different things, but you will see over the course of the next 12 months or 11 months, we will jump into more specific topics with case studies and more clinical value specifics to different types of wound closure, hemostasis, lots of different things that we can talk about. Fantastic. The answer was 100% said yes, so that's exciting for us. So Sandy, I'm going to turn it over to you. But again, thanks everyone for being here, for joining us. We are just really excited about the year and hopefully seeing each of you next year or next month. And thanks again to the faculty. You guys are fantastic.